Good evening, dear doctor. Myself Jagdish Joshi. I'm Senior Vice President for McLeod's Pharma Division. Welcome each one of you for this webinar on early diagnosis and management of hypertension. As you know, incidence of hypertension are increasing day by day, and early diagnosis play important role in the management and prevention of hypertension complications. We at Pharma Division have one brand, that's our telmisartan, which is a brand name Telmisartan. Entire range is there. And I'm thankful to Dr. Ketan Mehta, who will be sharing his experience on the practical aspect of the hypertension. With this, I hand over session to Dr. Amit Kamra. Dr. Amit Kamra, please.
Sir, thank you. Good evening, everybody. On behalf of McLeod's, we welcome you to this evening webinar on hypertension. And we have none other than Professor Ketan Mehta, who will take us through the journey of hypertension, especially keeping it in light the general practitioners. And it's our pleasure to tell you that you can ask questions in regional languages as well to Dr. Mehta, who will happily answer your question in regional languages. Dr. Ketan Mehta has been practicing medicine in Mumbai for the past 2 decades, and sir is practicing at Asian Heart Institute at Bandra Kurla Complex, Suchak Hospital, Namhana Hospital, and Lifeline Medicare Hospital. Sir is the Honorary General Secretary of ISC from the year 2020 to 2022. Sir is also the Vice President of Indian Medical Association Mumbai West Zone for the year 2019 and 20. Sir was the convener for NatCon 2017. Sir was the Vice President of IMA for Maharashtra State in the year 2015 and 16. Sir was the Treasurer of IMA Mumbai West Zone for the year 2018 and 19. Sir was the Organizing Secretary of Mastercon in the year 2015. And Sir serves as an editorial board member of JAPI, which is a very renowned journal from India, and Journal of Medical Nutrition and Nutraceuticals. With this, I welcome Dr. Mehta and hand over the session to him. Sir, please.
Thank you, Amit, for the kind words. So at the onset, I would like to thank Mr. Jagdish Joshi, Dr. Amit, and the McLeod's for inviting me for sharing my views. So दोस्तों, कोई भी अच्छी चीज की शुरुआत हम श्री गणेश जी से करते हैं. And what better than we can have to having this webinar during Ganesh festival. So let's take the blessings from Shri Ganesha. I'm sure many of you might be having at your own place of maybe 1.5 days or 3 days or 5 days. Friends, today what we are going to discuss is early diagnosis and management of hypertension. Now, before we start, I would like to ask you a question, that what is the similarity between a cardiologist and Gabbar Singh? All of you must have heard of Gabbar Singh, the Sholay fame, who had really made the entry as a villain and which made so popular. So the similarity is both of them will say, तूने बहुत नमक खाया है, ले अब गोली खा. So that is how नमक ज्यादा खाया, so अब गोली खाने का वक्त आ गया. So friends, let's talk of hypertension, what we record as blood pressure. But remember, it is only a marker of the bigger problem. The truth is, hypertension is a multi-organ systemic disease. The problem is, hypertension is asymptomatic in 85% of cases. आप लोगों को पता ही नहीं चलेगा ये patient को hypertension है. So many of them, especially in current time, they may be doing teleconsultation and they will just mention about their other problems. Even they may not know that they are having hypertension. Now, one of the study, it was our own data which was published in European Society of Cardiology, that 1 in 5 young adults in India has high blood pressure. Now imagine the country like India, 1 in 5, that means it equates to almost 80 million people. That means more than the entire UK population. That means this is the burden of hypertensive patients, and especially in a young adult we are having in our country. Now remember one thing, that high prevalence and poor BP control rate, which has been found across India, be it any country, be it urban or be it rural places. You take the city like even Bangalore, Chandigarh, Chennai, Jaipur, Trivandrum, and this is the data which was published in American Journal of Hypertension. So which shows that we not only we have a high prevalence, but we also have a poor blood pressure control rate. And to understand that, there's a simple rule of 50. When you talk of hypertension, only 50% has been diagnosed, 50% are not diagnosed. Out of those 50% diagnosed, only 50% are treated, 50% are not treated. Now, why they are not treated? Because the patient feels that they don't need to take medicine because they don't have symptoms. And that's the very much wrong myths and all which they have got, which needs to be corrected. And if you take those 50% who are treated, only 50% are controlled, another 50% are not controlled. So if you talk of a complete set of hypertension, of 100 hypertensive patients, only 12.5% are on treatment and are very well controlled. That means 87.5% are out of control. Now, why we are talking so much about this blood pressure and uncontrolled high BP? Because it leads to increase in CV mortality risk. Now, this figure, it's so much alarming. I'm sure all of you must be aware about this data from Lancet, that if somebody has a blood pressure of 115 by 75, vis-a-vis, if somebody has blood pressure of 135/85, what you will do, somebody who comes for the first time and you see the pressure of 135/85, you will tell him, don't worry, your pressure is normal. But remember that compared to the people who has a 115/75, if they have a 135/85, it causes twofold rise in cardiovascular mortality risk, which is an amazing number. Same thing happens with every 20 millimeters mercury rise, and with every 10 millimeters of mercury in systolic and diastolic, you have double the fold of increase in the risk of CV mortality risk. So that is where we are worried about. Now remember the word from Sir Richard Doll, death is inevitable, but premature death is not. And we should try and prevent that. And the words from Alvin Toffler, which states that illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And we are here to learn, unlearn, and relearn about the hypertension. So when you are seeing a patient of hypertension, I'm sure आप लोग OPD में routinely these patients देखते हैं. What are the objectives of evaluating these patients? There are three main objectives. First, to assess the lifestyle and other cardiovascular risk or concomitant disorders that may affect prognosis and guide the treatment. That means patient को अगर hypertension है तो उसके साथ में और क्या-क्या बीमारी है. Second, to reveal identifiable cause of BP. ये blood pressure होने की क्या कोई और वजह है? And the third factor, to assess the presence or absence of target organ damage and cardiovascular disease. Because of blood pressure, patient को कोई और target organ में damage हुआ है क्या? That means you are evaluating something like a 3 generations. First, उसकी वजह क्या है? Means parents की वजह से है क्या है? Second, साथ में concomitant disease क्या है? और third factor रहेगा कि blood pressure की वजह से कोई target organ damage है कि नहीं? Now, you should remember there are certain identifiable causes of hypertension, and you should try and look out for this condition, especially when you see anybody who is a young hypertensive. Now, by definition, young hypertensive means that is anybody below the age of 40 years with hypertension and anybody below the age of 35 with a family history of hypertension. That means those who don't have a family history below 40 with family history below 35. And what are the causes? Sleep apnea, most neglected cause of hypertension. Drug induced, sometimes patient may be taking NSAIDs for a long period of time. Primary aldosteronism, chronic kidney disease, renovascular disease, chronic steroid therapy, Cushing syndrome, pheochromocytoma, coarctation of aorta. So it is definitely mandatory for you. If you are detecting somebody or young hypertensive, you should find out, is there any cause of hypertension? Don't just label him as a primary or an idiopathic hypertension. Okay, Now, once you have diagnosed, what are the laboratory tests and diagnostics? Remember, obviously, all of you get tempted to start the treatment, and all of you are, I'm sure, masters in treating hypertension because you all people are seeing more number of cases of hypertension than what we see. But remember, at the onset, certain tests which are absolutely mandatory, do not forget to get it done, which includes ECG, urine analysis, blood glucose, hematocrit means you will get a complete CBC, serum potassium, serum creatinine, serum calcium. Or else you can ask for a renal function test, which will include all three, lipid profile, and thyroid serum TSH. Only one eliminating test for thyroid dysfunction. So these are the tests which you should not forget. You should get it done. Okay, now let's see what new guidelines say. Because there are a lot of guidelines which come, and you must be aware, European Society of Cardiology, European Society of Hypertension, they came out with the latest guideline in 2018, American Heart 2017. Now, there are different cutoff given by different organization and different bodies, and you get confused. And afterwards, the latest one which came was International Society of Hypertension Global Hypertension Practice Guidelines, which came in 2020. And this is the cutoff. I don't want you to go into the details of it because we are Indian, hum hai Hindustani, make in India, made in India, and our Prime Minister Narendra Modi always pushes for Indians. So I would put stress on our Indian guidelines on hypertension 4, which came in 2019. And I'm sure all of you must be aware about it, in which the category of optimal pressure, when we are looking at it, is less than 120 by 80, normal is less than 130 by 85, high normal is 130 to 139, and 85 to 89. Hypertension is divided into 3 stages, stage 1, stage 2, stage 3. For stage 1, 140 to 159, stage 2, 160 to 179, and stage 3, more than 180. And similarly for diastolic, it is 90 to 99, 100 to 109, or more than 110, which will come stage 3. And similarly, you have got an isolated systolic hypertension, where only systolic pressures are increased. So we as an Indian, I would strongly recommend we should follow the Indian guidelines, where we have a different stages, stage 1, stage 2, stage 3. Now remember, category of high normal, you should be careful. Somebody who has got a pressure of between 130 to 139 or diastolic of 85 to 89, don't just tell them that you are normal. Tell them you are high normal. You need to be vigilant. You should be keeping a check on it because you don't know in what stage they will become or go into a stage of hypertension. Now, there is something which has come up in last couple of years about the ambulatory blood pressure and home blood pressure monitoring. Now, a lot of stress has been given about ambulatory BP monitoring. I'm sure all of you are aware that 24 hours ambulatory BP monitoring which has been put. And when we talk of office blood pressure, which is more than 140 by 90, when we check in a clinic BP, but when you do ambulatory BP monitoring, if it is more than 130 by 80, it is considered as a hypertension. So remember, ambulatory BP monitoring cutoff is 130 by 80. And somebody who is doing home monitoring, so home BP mean monitoring, if it is more than 135 by 85, it is again considered as hypertension. So don't wait for a home BP to reach 140 by 90. So home BP cutoff 135 by 85, ambulatory BP mean 130 by 80, and for your office BP 149. Now, there are certain thresholds for treatment and target BP to be achieved, which you should remember. And I will talk of only Indian guidelines. So, by all means, the threshold, that means at what point you will start blood pressure treatment. And that is across it is 140 by 90, which we know, except in cases of somebody who has a coronary artery disease or heart failure, where it is 130 by 80. Remember that. 130 by 80 in coronary artery disease and heart failure. Okay, and what is the target BP? Now, this is the change which has happened over a period of time. We were talking of BP target less than 140. No. So now we try to maintain and say that it is 130 by 140 and diastolic 70 to 80. Now, this is the one thing. Diastolic, we no longer consider less than 90. We try and achieve the target BP to between 70 to 80. Again, there are three categories where target BP be still lower, that is in high atherosclerotic cardiovascular disease, coronary artery disease, and heart failure, where you will try and achieve blood pressure of 120 to 130 systolic or 70 to 80 diastolic. So this you should be aware, it should be drilled into your mind that this is what you are looking at. Don't get satisfied with the higher values also. So remember, guidelines that are not followed are of no value. You should follow them. Now, when we talk of goals of therapy, lifestyle intervention, which all of you know, which includes weight reduction, the dietary pattern, dietary sodium restriction, physical activity, alcohol moderation, tobacco. So these are the factors which needs to be followed. In fact, when I shown this slide in one of the webinars, the one question came that you showed in intervention, weight reduction, dietary restriction, and tobacco. So does tobacco causes reduction in blood pressure? So then I have started showing, no, it is a tobacco abstinence which is required for blood pressure control and not starting of tobacco. So just keep it in mind. Okay. Now, when it comes to starting the therapy, what to choose from the ocean? You know, you have a huge ocean of antihypertensive. You have got 16 different classes of drugs, 117 approved molecules as on date, innumerable drug combinations, over 1,800 clinical trials of repute. There are 5 international societies on hypertension, 7 JNC guidelines so far, and 8th was the recommendation. So it was not 8 JNC guidelines, just to tell you. Then, of course, multiple target organ damage, many comorbidities, varied outcome of interest, and the cost constraint, which is a very crucial point. You know, somebody should not give away medicine because of the cost factor. So you need to choose widely. And in spite of that, there is no significant change in the proportion of hypertension under control, which we have seen over a period of time. Now, current antihypertensive armamentarium, if you see, the commonly which we are using is the CCBs or calcium channel blockers, AC inhibitors, ARBs, diuretics, beta blockers, alpha blockers, direct renin inhibitors, central sympatholytics, and vasodilators, which are the drug classes which we use it. So do we really make a choice? You know, somebody say you can start anything, but especially those who are fond of drinking, if you tell them, give me a drink, they will not be happy. They want a particular, their brand and a drink. Similarly, for each and every hypertensive, you need to make a choice. Now let's look at the case scenario. You know, nowadays it is a trend that people go for a health checkup. And similarly, one of your patients, who is a 46-year-old male working in a MNC executive, underwent executive health checkup. He is asymptomatic. He is chronic smoker, social drinker with sedentary habits, weight 86 kg, BMI of 32. So obviously he is obese. And in the health checkup, his BP was found to be 154 by 92 millimeters of mercury, pulse of 94. His investigations were within normal limit, except fasting sugar was 102, postprandial of 156, and HbA1c 6.3. So obviously he has got dysglycemia, he is pre-diabetic, and recently detected maybe first-time hypertension, he is obesity. So obviously he was advised lifestyle modification with BP monitoring, was asked that you keep a watch on your blood pressure and monitor. You may require a BP monitoring because it was the very first time detected. So it may happen that the doctor thought he could have a white coat hypertension. He said, you go to your family doctor and get it checked and keep a monitor. So obviously he was told that you will definitely require a lifestyle modification. So this gentleman was going to the family doctor absolutely from regular basis. So BP monitoring was follows, and these were the BP readings. So it was obviously persistently high. And over next 6 weeks, then he also started knowing his BP is high. He started little heaviness in the head. So he became little symptomatic with average BP of more than 150/90. So this is the common story. I'm sure all of you must be coming across this type of cases. So now my question is, which class of drug will be your choice? Will it be calcium channel blockers? Will it be beta blockers? Will it be ACE inhibitor or ARBs? Or will it be diuretics? Now, had it been an actual physical meeting, I would have asked the audience. So here being a virtual or webinar, obviously, I'm sure you must have started giving answer in your mind about that. But to give the answer to this, I will take you to the what is called as the ABCD approach of antihypertensive drug class. And again, this approach which comes from Indian guidelines on hypertension, which is the algorithm which is recommended for starting the therapy or combining the therapy. And I want you to focus on this. You need to put all your patients into two different categories, younger group and older group. Now, obviously, the definition would vary. What IGH has given, younger means less than 55 years and older means more than 55 years. So step one is A, that is A is ACE inhibitor or ARB is the preferred class of drugs, or the newer beta blockers, and that is the B, which is into bracket. So it is not the first choice, but can also be used. And for older class, C, that is calcium channel blockers, or D, that is diuretic. So simple, young A or B, old C or D. That is step one. Now, step two, if the person is not controlled. Now, look at this. What is the combination suggested, be it any class? It is one from either A or B, whichever you started. You have to combine with C or D. So don't combine A plus B. It should be A or B, whichever you have started first. Combine it with C or D. And that is the recommendation which has come. Similarly, if it is not controlled in step 3, then what is recommended? Again, here it is not A plus B. Again, it is A plus B, A or B plus C plus D, and that is the combination. And in step 4, resistant hypertension, where you can add either alpha blocker or spironolactone or other diuretic. So this A, B, C, D approach, and if you remember this, it will be very easy for you to start the therapy as a monotherapy and to start a combination therapy if they are not controlled on this therapy. Simple enough? Okay, now let's look at our case. So after 2 weeks of treatment, okay, now here I will give you, the patient was put on, as it was changeover, as it was a young hypertensive, the doctor decided he will put on a beta blocker for whatever reason. So he put him on a beta blocker. And after 2 weeks of treatment, his BP was 156/90. So what will you do for hypertension control? Obviously, you are not satisfied. So probably it would have been wiser if this patient would have been on A, that is ACE inhibitor or ARB. I'm sure would have got a better results. Okay, so subsequently changeover was put on ARB, and he was started with ARB, he continued. So apparently patient was all right for almost a year. And after 1 year, again, he went for executive health checkup. At that time, BP was found to be 138/86, fasting sugar 119, PP 154, HbA1c 6.7. So now he's gone into a stage of diabetes with dyslipidemia, as you can see, cholesterol 212, LDL 142, HDL 29, uric acid 7.8, that is with hyperuricemia. So what will be your choice of hypertension treatment? Again, what you need to be careful about, now he has got high uric acid. So you need to take care of the drugs which can cause elevation of uric acid, or you can offer a drug which can cause benefits in terms of uric acid. He has dyslipidemia, so you should be taking care of that. And he has got diabetes, which is obviously needs to be taken care of. So let's look at the pharmacological therapy, what are the guidelines which telling for selecting the most appropriate first-line antihypertensive drugs? So when you are starting as a monotherapy first, I will just go into the class of drugs and definite indications. So diuretics, which will be preferred if the person is heart failure or elderly patient or having systolic hypertension. Beta blockers preferred for angina, post-MI, tachyarrhythmia, heart failure. CCBs are preferred for metabolic syndrome, angina, elderly, systolic hypertension, and diabetes. AC inhibitors are preferred again for metabolic syndrome, heart failure, left ventricular dysfunction, post-myocardial infarction, patients with a significant proteinuria and diabetes. ARBs are preferred in metabolic syndrome, like our patient who has got obesity, dysglycemia, hyperuricemia, dyslipidemia, hypertension is a classical metabolic syndrome. So diabetes mellitus, proteinuria, LV dysfunction, and remember, I'm sure all of you must have seen this AC inhibitor-induced cough. So many of our patients who are on AC inhibitor are unable to continue with AC inhibitor because of intractable cough, and which is so nagging and irritating. The patient will come and tell that, can you change over to something better? Now, why I am saying this? Because a very important thing is compliance with the antihypertensive agents. And this is one data I could not resist myself to put this slide, because you must understand what is the compliance with various different classes of antihypertensive agents. And it has been shown that somebody who is on ARB has got the highest compliance, and the discontinuation rate is the lowest with ARB, which is 29%. With AC inhibitor, it is still higher, 33%. CCB, 41% discontinuation rate. Beta blocker, 50%. And diuretics is the highest, 56% discontinuation rate. So compliance is lowest with diuretics and highest with ARB. And that gives us a confidence in which class of drug we should be using if there is no compelling indications to use particular class of drugs. Another factors I would like to bring to your notice about, somebody who has got a uncontrolled hypertension, it causes left ventricular hypertrophy. So the drugs which we are giving, can it reverse LV mass? And this is the result of a meta-analysis. Again, it has been shown when we talk of regression of LV mass, it is highest with ARBs. You have something with AC inhibitor, with calcium antagonist, but the advantage is highest with ARBs. And another factor which I would like to keep in mind, risk of type 2 diabetes with antihypertensive therapy is, again, the benefit is maximum with ARB when you seek or compare with other therapies also. Now, what are the causes of inadequate response to monotherapy? Like our gentleman, which did not respond. So you should keep it in mind. Non-compliance, that is somebody who doesn't take medicine. Again, cost is very important factor. You need to see that the therapy which you have prescribed, is the patient able to afford? And if not, obviously you should go for a therapy or a molecule or a brand which is definitely of a lower cost. And other factors like secondary hypertension, volume overload, there could be a specific drug-specific intolerance, and sometimes activation of counter-regulatory mechanisms can be there. So today's paradigm is that gone are the days of monotherapy, and it is the era of combination therapy. So why is it so? Because this paradigm shift in hypertension therapy has come because it is not just reduction in blood pressure we are looking at it. Today, we must try to alter the modifiable risk factor, keep the systolic BP less than 130, diastolic BP less than 80, prevent or halt or reduce the target of organ damage. So we are not just looking reduction in the numbers, we also see how much additional benefit we can give by taking care of left ventricular hypertrophy, coronary heart disease, congestive heart failure, cerebrovascular accidents, chronic renal failure, peripheral vascular disease, and retinopathy. If we can take care of all these target organ damage, nothing like it. We should prevent or control diabetes if it is there together, prevent and control of dyslipidemia. So overall, what we are looking at, reduction in morbidity and mortality and improving quality, that is quality adjusted life years. What we want is a better quality for our patients. So there comes the role of combination therapy for hypertension. We Indians have been following the combination therapy for quite many years because we know how this combination, which has taken the market for so many years. Similarly, the hypertensive combinations have taken the market. In fact, in 13th May 2009 was the first time US FDA approved combination therapy as a first line treatment for hypertension. So now it has been US approved also. So why combinations? Because if goal BP is not achieved by a single drug in full dosage, then adding another agent will help achieve the goal BP. Two agents sometimes nullify each other's side effects. Fixed dose combination will reduce the number of tablets. That's the very important thing. If you can reduce the pill burden, compliance can improve. Once daily formulations are good for compliance. So try to give, obviously, once a day. If you remember good old times, you used to give nifedipine, which was a short acting. You used to give every 6 hourly or 8 hourly, and you can imagine what will happen to compliance over a period of time. Sustained release or long-acting formulations for 24 hours BP control is required. And we know if 3 drugs cannot achieve a goal BP, then we know it is a case of resistant hypertension where we should be tackling in a different way. Now, when it comes to drug combinations in hypertension, this is a beautiful chart which has come by American Society of Hypertension recommendation. And I want you to focus on which are the preferred combinations. So that is very important. So you have a preferred combinations are AC inhibitor with diuretic, ARB with diuretic, AC inhibitor with CCB, and ARB with CCB. So these are the 4 combinations which are the preferred agent. So if can be given in a single pill, it will definitely will have a great success rate. So that is what I want you to focus on it. Now, I cannot resist myself but giving you about the pleiotropic effects of RAS blockade, that is for AC inhibitor and ARBs. We know I would not go into the pathway of how from the angiotensinogen to angiotensin 1 gets converted angiotensin 2 and angiotensin 2 receptors, which when they get stimulated, you have got a 81 and 82 receptors. So 81 receptors has got a harmful effects, 82 has a beneficial effects. I just want you to focus on this. What are the harmful effects of angiotensin 2? It has an effect on heart, causing myocardial hypertrophy, interstitial fibrosis, and inotropic effects. With coronaries, it has got the endothelial dysfunction with reduction in nitric oxide, coronary constriction, oxidative stress, which can increase inflammation, atheroma. On kidneys, intraglomerular pressure will increase, proteinuria, increase in sodium reabsorption, glomerular growth and fibrosis, increase ADH. For adrenals, increase aldosterone, augment sympathetic nervous system, and has got an effect on coagulation by causing increased fibrinogen, increased PI1 and platelet aggregation. So these are so much deleterious effect of angiotensin 2, and if we can block that, we can achieve significant benefit. And these are the pleiotropic effects by blocking the angiotensin 2 receptors. It will reduce ischemic heart disease because there is a genetic link of RAS and coronary artery disease. AC inhibitor circulatory effects are cardioprotective, so hemodynamic, neuroendocrine benefits, reduction in endothelial dysfunction. These are the drugs which are anti-proliferative, anti-atherogenic, anti-thrombotic, and positive tissue effects. And all of you know about these various ARBs or angiotensin 2 receptor blockers, which are called sartans, and you have got losartan, telmisartan, valsartan, irbesartan, olmesartan, candesartan, neo and femasartan, which have come. To give you an idea, we have in our country telmisartan, which is ruling number 1. We know the advantages, the double-digit BP reduction, and advantages truly once a day, and the dosage flexibility which we have got. Globally, even the sartans are taking away the first lead role, and of which, surprisingly, just to give you an idea, valsartan is globally number 1. In our country, telmisartan, which is being used as number 1. So Choice of, now I would come to my last few couple of slides where I want you to rapid fire round that after giving you an idea about this, what should be the choice of antihypertensive drug in various conditions. So if somebody has got unstable angina and you have to give hypertensive drug, so obviously the drugs can be choice will be beta blockers or calcium channel blockers. If it is a post-MI, then again beta blockers or a RAS blockade, that is ACE inhibitor or ARB. For diabetes, it will be ACE inhibitor or ARBs. For CCF or LV dysfunction, again ACE inhibitor or ARBs. COPD, asthma, again here I would put a stress, the drug to be avoided or not the first choice would be a beta blockers. CKD, now again a very, very faint line, early CKD, in fact, the use of ARB and ACE inhibitor is preferred to reduce or halt or slow down the progression of CKD. And of course, if it is an advanced CKD, you are going to avoid that. For peripheral arterial disease, it is calcium channel blockers which are preferred. For a post-stroke, again, calcium channel blockers and diuretics which are preferred. Of course, there are some role of ACE inhibitor and ARB is also there. For thyroid disorder, somebody who has got hyperthyroidism, obviously the drug of choice will be beta blockers. Somebody who has a hypothyroidism and has put on thyroid replacement therapy and now detected hypertension, again I would put it beta blockers because if they have got thyroid supplement, they have a tendency to go into a heart rate which can go up. So beta blocker would be a drug of choice. Hyperuricemia, the drugs to be avoided would be diuretic. In fact, there are few drugs, especially sartans, telmisartan and losartan, which has got found to have a beneficial effect if they are used in patients of hyperuricemia. Depression, the drugs to be avoided are beta blockers, very clearly, because it can propensity to cause further depression. Volume overload state, choice would be diuretics, obviously it will have a beneficial effect. And very elderly, where you are expecting an isolated systolic hypertension, so a calcium channel blocker or a diuretic which can be used over here. Now, this is one chart in which it is given the antihypertensive agents based on the favorable outcome data from various clinical trials. If you look at be it CHF, post-MI, coronary artery disease risk, diabetes, nephropathy, stroke prevention, if you see the drugs which has got a maximum benefits are ACE inhibitor and ARBs. Obviously, then depending on other indication, you can use the other class of drugs. So you need to use drug wisely and choose wisely when you are starting somebody on a antihypertensive agents. And remember, there are other effects of hypertensive drugs, and especially you are worried about, as we discussed our case, he had dysglycemia, he had dyslipidemia. Now look at this data. What happens to when you give somebody a inhibitor or ARB? Effects on dysglycemia, yes, it has a beneficial effect. Dyslipidemia, beneficial effect. It can reduce lipids, it can reduce sugars marginally. What about CCBs? They are neutral. Diuretics can increase, beta blockers can increase their levels. So you need to be very careful when you are selecting the class of drugs. And that reminds me the quote from Sir Professor William Osler, who is considered as the father of modern medicine, and who stated that one of the first duties of the physician is to educate the masses not to take medicine. And you will be wondering, how come he's talking about not taking medicine? And then he clarifies in his subsequently that the person who takes medicine must recover twice, once from the disease and once from the medicine, which is so much true. Today, each and every medicine has got their own effect and the side effect. You should be aware about it and you can take care of it. So, ladies and gentlemen, to summarize the treatment strategies, 5 classes of drugs can be recommended as a first-line treatment for stage 1 or 2 hypertension, includes ACE inhibitor, angiotensin receptor blockers, calcium channel blockers, diuretics, and newer beta blockers. Now, combination therapy with different classes of drug with different mechanism of action can achieve effective control of BP with minimal side effects. Younger individuals have a high renin hypertension, hence ACE inhibitor or ARB or newer beta blockers are preferred. While older individuals have low renin hypertension and hence diuretics or CCBs are preferred as first-line agents. RAS blockade is the foundation of antihypertensive therapy, and initial combination therapy should almost always contain a RAS blocker in most patients, where we use predominantly a sartan, which is being used with other class of drugs. So at the end, I would state that what we receive is information, what we preserve is knowledge, what we use is intelligence. But what, when, and how we use it is our wisdom. And we can use and choose the drug wisely. And the words from Carl Rogers, who says that the only person who is educated is the one who has learned how to learn and change. And we all must learn and unlearn and relearn, so that every time what we get a newer concepts, we should be clear about it, and which we can give the benefit to our patients. So thank you so much for your patient hearing, and whatever questions, जो भी आपके सवाल है, चाहे इंग्लिश, हिंदी, मराठी, गुजराती और संस्कृत, beyond which उसके आगे मैं आंसर नहीं दे पाऊंगा. So Dr. Amit will take the questions, and thank you so much for your patient hearing. Over to you, Amit.
Yes, sir. Thank you so much, sir. That was a wonderful enlightenment on hypertension. Sir, I have a couple of questions which I received from the attending doctors. Dr. Suresh Patel from Kadegaon asked that what is the treatment of only diastolic hypertension? Say patient has a blood pressure of 130 by 110 millimeters of mercury.
Very good questions. So, of course, we do see patients with diastolic hypertension, which usually happens in the younger individuals. And these are the patients where we prefer to use the RAS blockade. So sartan are the first preferred class of drugs, or ACE inhibitors. If required, beta blockers can be used, but please don't use calcium channel blockers or diuretics in this class of patients. So when you have isolated diastolic hypertension, it is the sartan, ACE inhibitor, and beta blockers.
Right, so thanks for enlightening on this. So Dr. Shripad from Pune asked that do we always need to have ambulatory blood pressure monitoring before starting antihypertensive treatment?
No, definitely not required. It is only in doubtful cases. It may happen that, the patient says that when I go to some other doctor, or when I go to my family physician, my blood pressure is always controlled. And when I come to you, my pressure is always high. And you also wondering what is happening. Is it a white coat hypertension, if you have doubt, or somebody who has got a stress-induced hypertension? So when you have doubtful case scenarios where you want to rule out or rule in hypertension, that is the time you are going to use ABPM, not in all patients of hypertension.
Sir, I have a couple of questions related to the COVID pandemic and hypertension, which come from Dr. Ratnakar from Boyser, Dr. Arvind. So, sir, basically we can answer them in 3 steps. Are ACE inhibitors and ARBs contraindicated in COVID? What can be the complications a hypertensive patients can undergo if he suffers from COVID? And thirdly, are there any concerns with the compliance of therapy currently?
Yes, very good question. With the current scenario which is going on, and India is marching at stage 3, very soon going to take over Brazil. It is literally like a rat race where which country is running for war. Now, all this controversy started initially when the 2 papers came in NEJM and the Lancet, which created the controversy about that since the coronavirus or SARS-CoV-2 act via the ACE receptors, the controversy came that somebody who will be taking ACE inhibitor will have a definitely more florid presentation of the disease and can have likely to have a worst outcome. But subsequently, it has been made clear by European Society of Cardiology, American College of Cardiology, International Society of Hypertension, and all bodies that though SARS-CoV-2 act via the ACE pathways, it has nothing to do with ACE inhibitor, which has been caused by these drug therapies, whether we used all enalapril, lisinopril, or sartans ARBs compound. So outcome, it doesn't change. There is no need to worry. In fact, afterwards, the paper which came subsequently has shown that those who happen to be on a RAS blockade therapy, they found to have a beneficial effect. In fact, so those who are taking for hypertension, either ACE inhibitor or ARB, should continue to take during COVID times if the pressures are on a higher side. Of course, if the blood pressure drops, you need to stop antihypertensive timing. That's a different thing. But otherwise, if they are hypertensive, you don't have to change over. In fact, the outcome is going to be better if they are on ACE inhibitor or ARBs. Another point is whether the patients of hypertension has got a higher risk of acquiring infection. No, there is no higher risk. The only thing is the complications can be more in those hypertensive, especially who are uncontrolled hypertensive. So uncontrolled hypertension has got literally more chances of getting a complications. But otherwise, controlled hypertension, no need to worry. Those who are on ACE or ARBs, please don't stop that.
Right, sir. So thanks for enlightening on that, because that was a major confusion when the COVID era started. And with time, I think we are getting better answers. Sir, a common question that is coming is choice of antihypertensive in young patients, say less than 40 years of age, choice of antihypertensive in diabetes, and choice of antihypertensive in CKD patients. That's asked by a number of audience.
Okay. So obviously one would be young hypertensive, as we have discussed over here. It has to be A or into bracket B, as I mentioned. A means obviously you are talking of ACE inhibitor and ARB. Now let me just give my personal experience. When we are talking as antihypertensive, all of us aware ACE inhibitor were the first class of drug to get introduced before ARBs came into the market. Our experience with ACE inhibitor as antihypertensive, they are very mild antihypertensive. So if you are going to use as an antihypertensive agent any of the RAS blockade therapy, my preferred choice would be definitely it is going to be ARBs. So young hypertensives would be ARB would be the first choice. I would in ARB, obviously nowadays what we are going to choose, telmisartan, which has got a definitely such a huge data is there, but you can use other sartan also depending on your experience and your comfort level also. The only indication where you can go for a beta blocker, that is another class, would be the somebody who has got a high sympathetic drive. So if you see somebody who has got a lot of anxiety state, whose pulse rate is 100, 95, somebody whose heart rate is above 90 and has got a young hypertension, then you would use beta blocker. But somebody whose heart rate is 70, 80, or has got only that, I would prefer to use ARB. So that about young hypertension. Second category about diabetics. Of course, for diabetics, the class choice of drugs would be RAS blockade therapy. So again, it will come to ARB and ACE inhibitor as a first choice of drug. That is clear. If comes to CKD patients, now for CKD, again it will come if it is, are we talking of early CKD or advanced? So which stage of CKD or what is the EGFR? So if it is an early CKD, we would prefer to use again RAS blockade. You need to be careful. It's a double-edged sword because in CKD, it can cause we know when you start RAS blockade, there will be a slight rise in creatinine and potassium levels. You need to monitor them. So if somebody whose serum potassium jumps drastically, you need to discontinue. Somebody whose creatinine starts rising, continue to rise, again, you need to discontinue. A small rise in creatinine, which is anticipated after starting a RAS blockade, don't get panicked about it. But if it is continue to rise, you need to stop it. So that will be the one. Now, if somebody who has got an advanced CKD, where calcium channel blockers are the preferred class of drugs which can be used. So if it is a first agent, yeah, early CKD, RAS blockade, that is ARB or S. If it is an advanced CKD, then you use calcium channel blockers. Now, again, I will give you data for CKD and use of RAS blockade. For somebody who has got diabetic nephropathy, say with CKD, so again, the choice of drug would be sartans. So where ARB is preferred over ACE inhibitor. So if you want to prevent the onset of nephropathy, again, sartan is preferred. If somebody has got established nephropathy, then you can use ACE inhibitor. So that's a little difference which you can differentiate. Thank you.
Thanks for enlightening on this, sir. Sir, I have a couple of questions on clinical selection of diuretics. Dr. Sharad Singh asked that how do we clinically select in between the two diuretics, that is hydrochlorothiazide and chlorthalidone?
Yes. Now, obviously, you have got, in fact, I would say indapamide is the another diuretic which is used as an antihypertensive. So we have been using all three class of drugs. Now, hydrochlorothiazide and chlorthalidone coming from the one category, indapamide is coming from different category. Now, you must remember, if you have to use the equipotent, efficacy-wise, yes, it is not the equipotent. So when you talk of 12.5 milligram of hydrochlorothiazide, it is equivalent to 6.25 of chlorthalidone. So when you are to use HCTZ, you require a higher dose. When you require a chlorthalidone, it's a lower dose, but the efficacy would be the same. Side effect profile wise also the same. The data which is there, which has been studied, chlorthalidone has been studied much more than hydrochlorothiazide, but efficacy wise, yes, we have seen the results with both. If you talk of indapamide, yes, indapamide has got a little more data when we talk of a post-stroke patients where it has got little more data. But only more dangerous of this in causing electrolyte imbalance is indapamide, especially when used in an elderly population. So you need to choose for what purpose you are using and the dose which you are selecting for it.
Right, sir. Sir, thanks for that. Sir, Dr. Nilesh from Nagpur asked that can two beta blockers be used together concurrently to achieve target BP and heart rate?
Okay, now why you want to use shirt and t-shirt both? So you have a good t-shirt or you can select the good branded shirt. It is, you can't put on two, you will be uncomfortable. So same thing, you use one drug, I mean one beta blocker, whichever you are comfortable with. Again, when you are using new, I mean as an antihypertensive, I would stress that the drugs which has been newer beta blockers with additional properties. So you have got a bisoprolol, metoprolol, succinate, nebivolol. These are the drugs which has been recommended to use as antihypertensive. Thank you.
Sir, I have a question from Dr. Rajiv Kumar Yadav from Mumbai. What is the choice of antihypertensive in case patient has hyperuricemia with hypertension?
Very good question. So here, I would prefer to use a drug which has got a beneficial effect for hyperuricemia. And as I have shown that the sartan are the only class of drug which has shown benefits. So where there are trials where telmisartan and losartan both have shown to cause, and to some extent even olmesartan. So basically it is a ARB class of drugs which are preferred with hyperuricemia. Thank you.
Sir, multiple users have asked that how do you manage hypertension in pregnancy?
Okay, so
what are the safe drugs?
Yes. Due to the paucity of time, we could not cover that pregnancy aspect also. Very important question, and nowadays we are seeing so often hypertension in pregnancy, which can be like a hypertensive lady getting pregnant, and there could be a pregnancy-induced hypertension. So the first drug of choice will be labetalol. Labetalol is alpha plus beta blocker, which has an effect on that and which is found to be totally safe. Pregnancy where you have an additional tachycardia or you are expecting a high pulse rate, obviously it will take care of it. So labetalol is the drug which is preferred, which is relatively safe even for uterine, for myometrium also. So that is the drug which is preferred. You can go on increasing. You can start with 100 milligram, and you can go the easily up to safely. We have used 400 milligram and beyond also, which is totally safe. If earlier good old times, we used to give alpha methyl dopa, which is not available recently, so we will not be able to use that. If you have to add another class of drug, so that would be again a calcium channel blocker like nifedipine, which can be safely added. The class of drug which needs to be avoided are RAS blockade. So AC inhibitor and ARB, strict no for pregnancy. And if somebody who is on AC inhibitor or ARB, and if they are planning to conceive, they have to go off this drug prior to the plan for the conceiving. Thank you.
Sir, I have a question that in case the patient presents with a blood pressure of 180 by 100 in the OPD, what should be the first line of treatment?
Okay, so very practical question. So we need to see whether his blood pressure has been on a higher side the first time, or he has recorded or he has noticed this earlier also. So that is one important things. Now, somebody who has been for the very first time, don't get just panic. So whatever is he taking, you need to increase the dose of it. But somebody who's has been on a number of times and now has got this, so obviously you need to have or start with combination therapy. So you need to be careful. If he says my BP is always be on this 180, 170, so you can't start with the monotherapy. If he says this is my routine thing, but I'm not taking medicine, you need to start with combination therapy, where you will use, as I have shown on the chart, A plus either C or A plus D. That is preferably ARB with diuretic or ARB with calcium channel blocker. So like telmisartan plus amlodipine or telmisartan plus either hydrochlorothiazide or chlorthalidone. Thank you.
Right, sir. So thank you so much for taking time to attend all the questions. And I think we have no further questions. With this, I would like to thank you and hand over to Mr. Jagdish Joshi.
Thank you.
So it was really very nice session, sir, and very well explained all about A to Z as far as hypertension is concerned. I feel a layman like me has also understood a lot as far as hypertension, and I'm feeling that I should also start practice. That's not possible, but everything was explained so well that it's very well understood. Thank you so much for this presentation. Yes, sir. Just to share with the audience, McLeod as a company today, we are the 7th largest pharmaceutical company and very, very strong as far as in diabetic cardio segment. Telmijuice, that's our range of telmisartan. That's one of the most economical, understanding the spread or scene of the hypertension is concerned. We will definitely request wherever possible, try our brand. It will help us like these program in coming time also. So once again, thank you, Dr. Ketan, and thank you, audience, for here. Thank you so much, sir.
Thank you.
Bye.